I wanted to introduce myself. My name is Hank Freeman. I'm one of the interventional radiologists at Edison Radiology and at JFK. And all of you are here today to talk about fibroids, and that's what we're going to do. So again, my name is Hank Freeman. There's a big interventional radiology team. There are 5 of us at JFK, and a few of us do the procedure that I'm going to be talking to you about a little bit. So what is an interventional radiologist? Most of you probably haven't heard of them. It's not as common as a pediatrician or a cardiologist, but what we are we're basically image-guided surgeons. We're trained in radiology, and we're also trained in minimally invasive surgical techniques that are guided by radiology studies, such as CAT scan, X-ray, ultrasound, MRI. And we do procedures that used to be done open, meaning open like with a big surgical incision. We do these procedures now with a little tiny incision or a tiny nick. And the benefit of those are that there's a shorter recovery and there's a less of a risk for a complication. So what are uterine fibroids? They are benign tumors of the uterine smooth muscle. They are not considered to be cancer. Even though they're called a tumor, they never become malignant. They're referred to as myomas or leiomyomas. That's the technical term. There are different types: submucosal, intramural, and subserosal. And I'm going to go into detail about the different types of fibroids. Do we have a pointer? Do we have a pointer?
It might be on there.
Oh, is it? It's on this? Yes, okay. So the different types of fibroids. This one here, this is a uterus that's kind of cut like this. So say like cut in the coronal plane. A subserosal fibroid is a fibroid that's on the outside of the uterus, basically touching the external wall of the uterus. A submucosal fibroid is one that touches the lining of the uterus. And then an intramural fibroid is one that's just within the muscle layer of the uterus. So these different types, I'll go into detail about them. Submucosal fibroids are the ones that are on the inside. They touch the uterine lining. They're the least common, however, they cause the most symptoms. And the symptoms that they cause are heavy periods, prolonged periods. Basically, doc, I'm having my period for 7 days. I can't leave the house for the first 3 days because I'm bleeding so much. Doc, I can't wear white clothes anymore because I'm bleeding so much. They're also associated with infertility because there's a problem with the fetus implanting on the endometrial wall when these fibroids are pushing on the endometrial lining. Subserosal fibroids, these are the ones that develop on the outside of the uterus. They cause different symptoms. These symptoms cause bulk symptoms, which are symptoms that are basically because of what it's pushing upon. So the fibroids, if they're on the anterior or the front part of the uterus, can push on your bladder. They can make you feel like you have to go to the bathroom every 15 minutes. If the fibroids are on the back of the uterus, they can push up against your rectum and cause constipation. They also have a generalized, if they get big enough, they can cause symptoms, just a generalized fullness or pain within the pelvic area. Intramural fibroids are the most common, and they can really cause a whole bunch of symptoms, but mostly the bulk-related symptoms. So how common are uterine fibroids? About 25 to 50% of all women eventually develop some sort of fibroids. They're most frequent in the ages of 30s and 40s. And they're the most common tumor, even though they're not malignant, of the pelvis in females. However, even though about 25 to 50% of women develop fibroids, only about 10 to 30% of that subset become symptomatic. And really, the only reason to treat fibroids is if they do become symptomatic. So what is their cause? Truthfully, we don't really know exactly what the cause is. We know what things make it worse. And basically what makes it worse is your hormones. Anybody in the premenopausal state produces estrogen and produces progesterone. And the surge of these hormones cause the fibroids to grow. Kind of how I describe it is it's almost it's like the gas line towards the fibroids. You know, as the estrogen and progesterone are produced, which is a normal production in females who are premenopausal, basically that's the gas line that causes the fibroids to grow. When you go into menopause, that gas line is cut off and the fibroids will shrink. However, who knows when that will occur? That usually occurs between 50 and 55. Also, there is some sort of a genetic predisposition. We think, we're not exactly sure. We do know that there is a familial tendency that a lot of patients I see, their mother, their grandmother had hysterectomies in the past, and most likely those were due to fibroids. What causes uterine fibroids? Again, fibroids may dramatically increase in size during pregnancy. This is because your hormones surge during pregnancy. Your estrogen and progesterone get especially elevated during pregnancy. And when they do, the fibroids tend to grow at an exponential rate. After pregnancy is over, the fibroids usually shrink, but they don't shrink to nothing. They shrink just to their pre-pregnancy state. And again, they usually improve after menopause because that gas line of the estrogen and progesterone are cut off. So what are the symptoms of uterine fibroids? The most common thing that I see, and the thing that patients complain about most, are heavy, prolonged menstrual bleeding, sometimes with the passage of blood clots, and if it's severe enough, anemia can occur. The second most common symptom that I see is bulk symptoms, which are the pain, pressure, or feeling of fullness in the pelvis, abdomen, or lower back. Frequent urination or constipation, pain or bleeding during intercourse, and infertility. Excuse me. This is a schematic showing the different locations, how different locations of the fibroids will cause different symptoms. This is a schematic of the body kind of cut like this in the sagittal plane. So this is anterior, this is the anterior portion of your abdomen, and this is posterior or back. So it depends, if you see the fibroids, if they're pushing on the back portion here, they're pushing against the colon, and they can cause constipation. If they're on the anterior or front side of the uterus, they can push against the bladder, and they can cause urinary frequency or just the need to constantly go to the bathroom. If they're a little higher up towards the superior aspect of the uterus, they can cause abdominal wall distension. So it really depends where they're located. The location will determine the symptoms. So who gets fibroids? It increases with age till menopause. About 20% of women in their 20s, about 40% of women in their 40s have fibroids. Again, there is some sort of a genetic predisposition, and it is definitely more common in the African American ethnicity, the African American subset. I'd say probably about 75% of my patients are African American. There is a familial tendency, which goes with the genetic predisposition, but we don't really have an exact cause. Fibroids are usually diagnosed first by the gynecologist, who does a physical exam and does a pelvic exam and can usually feel the fibroids if they're big enough. Usually after that, the doctor will send you for some sort of imaging, and the first line of imaging is most often a pelvic ultrasound. A pelvic ultrasound is more of a screening test, but the best test for fibroids is an MRI. And an MRI can really visualize exactly where each fibroid is. It can also differentiate between fibroids and some other diseases. Specifically, there's a disease called adenomyosis, which mimics the symptoms of fibroids, heavy bleeding, bulk symptoms, but it's different, and it really can only be diagnosed with MRI. So here we see this is an MRI machine, and this is an ultrasound machine. Most people know ultrasound from their pregnancy. It's the same type of a study. And these are images from an MRI. This is the large anterior fibroid right here, this dark area. And on the ultrasound, it's a grayish area right here. Fibroids can be diagnosed with something called hysteroscopy, which is done by the gynecologist. This is when the gynecologist puts a scope through the vagina and can visualize any of the submucosal fibroids directly. How are they treated? So fibroids that do not cause symptoms do not need to be treated. That's really the first thing. A lot of people will come and talk to me and say, Doc, I was diagnosed with fibroids and they're growing, and the first thing I'll ask them is, what are your symptoms? And if they tell me I don't feel anything, it's just from an imaging study that showed the fibroids are growing, I tell them they don't need anything, they don't need any kind of intervention. The intervention really is only for those that are symptomatic. When they do cause symptoms, the first line therapy is usually drug therapy because it's not invasive, it's no risk. Hormone therapy, usually with birth control pills, can help with the bleeding, or non-steroidals, Aleve, Advil, things like that can help with the pain and discomfort. If those don't work, then we can move on to a more invasive modality. Many patients, the symptoms are controlled with these treatments and no other therapy is needed. However, a lot of people, this is really insufficient for their symptoms and they need to do something more invasive. A lot of times the OBGYNs will use a drug therapy called Lupron. What Lupron is, it's something called a gonadotropin releasing hormone agonist, which is a long word for basically saying that this drug will put you into menopause. It's a fake menopause. It basically stops your estrogen, it decreases your estrogen and progesterone production. As I said before, those are really the gas lines that will exacerbate the fibroids and cause the fibroids to grow. If we decrease the estrogen and progesterone, the fibroids will shrink and your symptoms will improve. However, you will also get all of the side effects of menopause. You will get hot flashes, you will get the osteoporosis, increased risk of heart disease. So a lot of patients don't really like Lupron therapy because of the side effects. If the drug therapies don't work, the next line is a more invasive modality. And I'm going to talk about a few different modalities. Myomectomy, endometrial ablation, high-frequency ultrasound, hysterectomy, and uterine fibroid embolization or uterine artery embolization. So first, a myomectomy. A myomectomy is a surgical procedure that's done by the gynecologist. Myomectomy, the surgeon will either go in through a hysteroscope through the vagina or through a laparoscope through the abdomen and physically cut out the fibroids. It does work decently well and it will remove the fibroids that are there. However, there is a very high recurrence rate with myomectomy, at least a 25% failure rate. And it's also a surgical procedure, so there is a convalescence period, and even though it's not major surgery, there is a chance of complications. This is a schematic showing a myomectomy. This is an abdominal myomectomy with a laparoscope. And this is a hysteroscopic myomectomy. This is the one done vaginally through a hysteroscope, where they go in through the hysteroscope and basically cut out the submucosal fibroid. These are images, maybe a little graphic, but showing an abdominal myomectomy. So endometrial ablation is another procedure that's done by the gynecologist. What this is, it's basically they use a bovie or a heat source to burn the endometrial lining. And what this is used for is the heavy bleeding, so the submucosal fibroids. This does not really treat the fibroids, however, it does treat the symptoms. So your bleeding will diminish because the endometrial lining will be ablated. However, over time, these symptoms will recur. There is also a risk of sterility. High-intensity focused ultrasound is a newer, more experimental technique. It's not really a surgical technique. It's done with MRI, and it's also done where they use high-frequency ultrasound to cause heat, and that high-frequency ultrasound will essentially burn the fibroids. This is something that's still experimental. It's pretty much not done on a regular basis anywhere. It's just in clinical trials. So hysterectomy, everybody's heard of a hysterectomy. Hysterectomy is basically surgical removal of the uterus. It is the gold standard for fibroid treatment. It's done by the gynecologist. It's removal of the fibroids and most of the time the ovaries. It's 100% effective. If you don't have a uterus, you can't have fibroids and you won't have any bleeding symptoms. However, it is major surgery. It can be done either vaginally through the vagina, or it can be done not laparoscopically. It can be done through an abdominal incision. The issue with a hysterectomy is it's very effective. However, there is a fair amount of potential complications. It's major surgery with general anesthesia. You have to stay in the hospital for at least a few days. So usually this is the first thing that patients are offered when they go see their OBGYN. If you have symptoms, they will say you can have a hysterectomy. So most patients who come to see me already don't want a hysterectomy, and I don't blame them. You know, hysterectomy is kind of an old school type procedure. It works, and it's great for things that are malignant or things like that, but for benign procedures, it seems a big procedure for something like fibroids, which is a benign process. So a hysterectomy is very common. About 600,000 hysterectomies are done per year, compared to about 40,000 myomectomies and about 25,000 uterine fibroid embolizations. It's the second most frequent surgical procedure, and about 90% of these are done for benign reasons, with the most common being fibroids. This is a funny quote, maybe not so funny, but it's a quote that I found from a while ago, from about 1969, from an OBGYN source. And one of the preeminent OBGYNs at the time, Dr. Wright, said, "The uterus has but one function, reproduction. After the last planned pregnancy, the uterus becomes a useless, bleeding, symptom-producing, potentially cancer-bearing organ, and therefore should be removed." I'm assuming Dr. Wright was a male. Today, I mean, we don't really think like that. You know, obviously the uterus, the major function of the uterus is reproduction. However, I understand why people don't want to have major surgery and have their uterus removed if they don't have to. Patients come to me, why not have a hysterectomy? Many reasons. Avoid surgical adverse effects or complications, avoid pelvic support issues, avoid bladder dysfunction that can be caused without the uterus. If the ovaries are taken out, you will go directly into menopause, and you can avoid that by not having the hysterectomy. There is a long hospitalization, at least a few days, sexual dysfunction, etc. So the last thing I want to talk to you about treatment-wise is a uterine fibroid or a uterine artery embolization, and how we do that. Basically, we as the interventional radiology team do the procedure. We do it in a fancy X-ray suite called an angiography suite. It's basically an OR with a real-time X-ray machine. Excuse me. So the procedure is done on the real-time X-ray machine. So what we do is we puncture the artery in the groin, and really that's the only incision. It's not even an incision, it's basically a needle prick. So we put the needle in, we put a wire in, and the rest of the procedure is done with me looking at the screen. So what we do is we take a little catheter and we put that catheter all the way into the uterine artery, which is the artery that feeds the uterus. Once we get to where we want to be, we inject tiny little particles. These tiny little particles will block the arterial flow to the fibroids, essentially causing the fibroids to become ischemic. So it's like when someone has a heart attack, there's a blockage of the artery in their heart. So we're essentially causing a fibroid attack. So we're stopping the blood supply to the fibroid, essentially causing it to die. And over the next week or so, that fibroid will be starved, no nutrients, no oxygen, and the fibroid will die and scar down. How we do it in our angiography suite. We have an anesthesiologist who gives conscious sedation, which is basically you'll be put out through an IV sedation, but there's no breathing tube. It's not general anesthesia. And we also use numbing medication in the groin, which is really the only potentially painful portion of the procedure. The procedure really takes about an hour. Usually it requires an overnight stay. Recently I've been dabbling with sending patients home the same day, but I think it's pretty safe to keep the patient overnight, have them discharged really at 8 o'clock in the morning the next day. How was uterine artery embolization discovered? It was really discovered by chance. What we used to do this procedure for was patients who had excessive bleeding in the postpartum state after they gave birth. Sometimes patients who gave birth, their uterus didn't contract well, and it would cause excessive bleeding. So we would do this procedure to stop the bleeding. We noticed after that procedure that a lot of these patients who had fibroids or had excessive bleeding, that their bleeding decreased over time. And then we started doing it for patients with fibroids, and there have been plenty of studies that have shown that it works very well. So what are the expectations after the procedure? There really are not a lot of complications, potential complications with this procedure. There is a small risk of infection, small risk of damage to the artery or damage to the arteries that feed the fibroid, a small risk of bleeding, but those are all probably in the 1% range. The complaint that I hear the most is that there can be a variable amount of pain after the procedure. The pain is caused by the fibroids dying. So usually the more fibroids you have, the more pain you will have. The bigger they are, the harder they fall. I treat everybody like they're going to have a lot of pain. So everybody gets pain medication like they're going to be in the higher side of the pain scale. And really that's the reason why I keep patients overnight, to control potential pain. About 25% of patients have no pain, about 50% have moderate, and about 25% have pretty significant pain. The good thing is that the pain only lasts a short amount of time. It is caused by the fibroids dying, and those fibroids take about a week to really completely die and start the scarring down process. So in about a week, 98% of patients don't have any more pain. So but truthfully, that first week can be relatively rough, depending on where you fit into that pain scale. So I usually tell my patients, take it easy for that first week. You know, if you're working, maybe take a week off and you can convalesce at home. Usually it's not bad enough that they can't do anything. They can go out, they can drive, they can do whatever you choose, but I would say no exertional activities and nothing too stressful. There's a pretty high success rate for fibroids with uterine artery embolization. It works best with bleeding symptoms. This is an oldish kind of slide. I'd say the success rate for bleeding symptoms is somewhere in the 90% range. For bulk symptoms, which are the fullness of the pelvis, the symptoms related to urinary frequency or constipation, it's about an 85% success rate. Also, the recurrence of fibroids are very rare with this type of procedure, because we're basically treating all of the fibroids at one time. If the fibroids do recur, it's usually because they grow after the procedure. So we don't stop. Potentially the fibroids can regrow, but if you think about it, your fibroids, most of you are, say, in the 30 to 40 age group. Your fibroids have basically been growing since you had your period. So if you start to grow them now, they're really not going to grow to the size that you are. They're not going to grow to the size that they are now over the time frame between now and when you go into menopause. So what is the mechanism of action for uterine artery embolization? So we use these little tiny gelatin particles called embospheres, and we inject them into the artery that feeds the uterus, and they essentially starve the uterus of oxygen and of nutrients, causing the fibroids to scar down and die. This is a schematic showing how I do the procedure. Basically, I puncture the artery in the groin. I put a little tube all the way down into the artery that feeds the left side of the uterus, injecting the particles and blocking the blood supply to the fibroid. Then inside your body, I pull this whole catheter back into the right uterine artery, and I do the same thing, okay? Basically killing all the fibroids within the uterus. This is another schematic showing these little beads and basically how they block the end arterial supply to the fibroids. This is a little slideshow showing the catheter in the uterine artery, the injection of the microscopic embospheres, and over time that fibroid will scar down. These are images from a uterine artery embolization showing, I don't know if this is projecting so well, but it shows the uterine artery here nice and large, and you really don't see any blood flow to the fibroids after the embolization. This is a better picture showing a large fibroid with, you only see the vascular flow, you don't see the actual fibroids in the angiogram. And then after the procedure, basically there's no blood supply to this fibroid. These are what the embo spheres look like. They come in a syringe, and they're little suspended particles. What is post-procedure care? Basically catheter site care. Basically we want to make sure that no bleeding occurs at the puncture site, because we are puncturing an artery, we're not puncturing a vein. And that's a lot different than a small cut. We want to make sure that that hole in the artery closes. So we're very diligent and conservative about that. Overnight admission, pain control, and then discharge instructions, usually, which really consists of medications for that first week. And I'll usually follow up with an MRI in 3 to 6 months, which will show how the fibroids have diminished in size and how there's no vascularity to them. So this is a procedure that has been being talked about more, and it's being done a lot more over the last 10 years. We all know Condoleezza Rice, who used to be Secretary of State. Basically, she, African-American female, more prone to uterine fibroids. She had a uterine artery embolization done in Washington by Dr. Spies, who's one of the preeminent interventional radiologists at Georgetown. Some questions that I usually get are, how will my fertility be affected? This is a question really there's no real good answer. There is a chance of you becoming slightly less fertile after the uterine artery embolization. There's about a 5% chance of you becoming less fertile. However, a lot of patients have come to me because they can't get pregnant. And if the fibroids are pushing on the lining and the fetus cannot implant on the endometrial lining, they can't get pregnant because of the fibroids. So shrinking those fibroids might improve their chances of pregnancy. But usually, if people are really concerned about fertility, I will lead them towards a myomectomy if that's something that they can have done. Will my insurance pay for fibroid embolization? Almost all insurance carriers do pay for fibroid embolization. The advantages, as we talked about, it treats all the fibroids simultaneously. It's minimally invasive. Complications are rare. Recurrence of fibroids are rare. There's a short recovery period, much shorter than surgery and significantly shorter than a hysterectomy. No scar, no adhesions, minimal blood loss. Basically, we don't use general anesthesia, we just use conscious sedation. And you don't have to remove your uterus. The disadvantages are about a 10% failure rate, and the pain after the procedure. Basically, that pain for the first week can be kind of bad. Bleeding is about a 90% success rate, pelvic pain about an 85% success rate. Same with the bulk-related symptoms. In summary, uterine artery embolization is a non-surgical procedure. It's minimally invasive. The recovery from the surgery is very rapid. In about a week, you should feel 100% normal with no scars. The treatment specifically targets the fibroids. It does not use hormones, and you will not have any hormonal side effects. And all fibroids are treated regardless of the size. Thank you very much.